Welcome back. I'll be talking about part 2.6 in an approach to vomiting and abdominal pain today. And the topic at hand would be imaging in the diagnosis of abdominal pain due to parenchymal organ distension. This will be part one. So this is a direct extension of the part 2.4 in this series. Um, so in that video, I had discussed the following points. I discussed the following case vignette. So we had a 35-year-old lady without any known prior comorbidities, no history of substance use or abuse, who had now presented with abdominal pain for the last 6 weeks. The pain was gradual in onset, persistent, non-progressive, deep-seated in the right upper quadrant, dull aching in or catching in character, moderate to severe, or rather moderately severe, and radiating to the right shoulder tip. This was associated with progressive abdominal distension, which was diffuse and was not associated with any episodes of vomiting or altered bowel habits. Again, there was no history suggestive of shortness of breath, jaundice, or cough. There was no relevant treatment history. The physical examination was remarkable in that there was bilateral pitting pedal edema. There was right upper quadrant tenderness and shifting dullness, but no guarding. So we had an ultrasound done outside, which was suggestive of moderate ascites. The liver is enlarged, but there was no features of cirrhosis or portal hypertension. So, by analysis of the history, we came to the conclusion that this was a significant localized abdominal pain without vomiting, with associated ascites, and we further opined that it was not due to pancreatitis or gastrointestinal tract obstruction or acute mesenteric ischemia. It was in fact due to parenchymal organ distension. Okay, so in that we thought that it could be the liver, it could this be the spleen and the kidney, but based on location, obviously we finally said that it was likely due to hepatic distension, and this hepatic distension could have been due to biliary outflow obstruction, hepatic venous outflow obstruction, and even acute hepatitis, resulting in distension of the hepatic capsule. Finally, because of the presence of significant ascites and the absence of significant hyperbilirubinemia or AST-ALT elevation in this patient, although I have not given the AST-ALT elevation here, but if that was the case, then it would imply that it was hepatic venous outflow obstruction, and we discussed how to differentiate between uh, hepatic arterial obstruction, hepatic venous obstruction, portal venous obstruction. So if that doesn't make sense to you, go back to part 2.4, and that's been discussed in great detail there. So that is approach to vomiting and or abdominal pain, part 2.4. Okay, 2.4, not 2.6. So that brings us to part 2.6, that is this discussion. In this discussion, we'll be reviewing the anatomy of the liver and specifically classifying the liver into what are called Couinaud's segments. We'll understand the general features of the liver on contrast enhanced imaging of the liver. We'll understand the role of imaging in the diagnosis of biliary tract obstruction, the role of imaging in the diagnosis of hepatic venous outflow obstruction, as is relevant in our case, which was just mentioned. Then we'll try to differentiate Budd-Chiari syndrome from elevated right atrial pressure and sinusoidal obstruction syndrome. We've done this clinically. Now we'll use radiology in the same context. In the next discussion, we'll talk about the role of imaging in the diagnosis of diffuse splenic disorders. We'll talk about the role of imaging in the diagnosis of diffuse renal parenchymal disorders. Then we'll talk about general features on contrast enhanced imaging of the kidney, findings that are specific to pyelonephritis on imaging, and the role of imaging in the diagnosis of renal and splenic infarcts. So all of this will be the next discussion because it's quite extensive, and otherwise the video would be too long. This is what I'll be discussing today. Okay, so now let's review the relevant anatomy of the liver, relevant clinical anatomy of the liver. So this is the schematic of the liver showing the Couinaud's segments. So these are essentially divided based on a plane that is essentially an axial plane, that is the plane of the portal vein bifurcation, and then the three major hepatic veins that divide the liver in with through these three plates. Okay, so the segments are numbered in a they're numbered in a clockwise direction when viewed from anterior. So this is segment 2, this is segment 3. Now these two segments are segment 4. The upper segment or the superior segment is called 4A and the lower segment is called 4B. Then we have again 5, 6, 7 and 8. Okay, so these are the segments, and essentially it's not very relevant for internal medicine to know exactly which segment is being talked about, but when you read a report, it becomes relevant because that's how radiologists describe it. Okay, so the first plane that is relevant is the plane of the right hepatic vein. So this is the right major hepatic vein and the plane that corresponds to it. Then the second plane that is responsible is the plane of the middle hepatic vein, and this would be the middle hepatic vein draining into the IVC. And the third plane, that vertical plane that is important, is the plane of the falciparum ligament. Now, or rather the falciform ligament. Okay, so now that is not exactly the same as the plane of the left hepatic vein, although clinically we often put one in place of the other. Now, the horizontal plane or the axial plane is the plane of the portal vein. Okay. Now, any increase in hepatic pressure results in different segments getting affected to different extents, and this is due to differences in the pressure head that is transferred to that different hepatic segments. Now, naturally, see, as the portal vein enters here, it and divides like this, the more distal segment of the liver is from this bifurcation, the less pressure will be transmitted to that. So you can go back and watch my video on focal segmental glomerulosclerosis and the histological variants of that for a detailed review on the physics behind that. But that is essentially the case. Okay. And essentially, on top of that, there are autoregulatory mechanisms, that is hepatic artery vasodilation whenever there is decreased perfusion of any portion of the liver. So that creates some very interesting clinical scenarios, which we'll just get. Okay, now segment 1 is not shown in this diagram. Uh, Not shown in this diagram. Okay, and it's actually located in between your segment 4A and 8, and it drains directly into the IVC by its own separate hepatic vein. So that's important because segment 1 is actually the caudate lobe, and therefore if these veins are obstructed, the caudate lobe is still free to continue to flow into the IVC, and often then starts taking over the function of the liver and then becomes larger in size, as we just see. Okay, so on cross-section anatomy, this is what it looks like. So you can see that this is a slightly upper segment because you can see the heart here. Now, just behind the heart, under the diaphragm, would be your segment 2, because we're going anti-clockwise and we're above. Then just next to that, this is the plane of the falciform ligament. Okay, to the right of that, we have segment 4A. Then we have the plane of the middle hepatic vein, and then to the posterior aspect and to the right of that, we have the segment number 8. Then we have segment number 7 behind that. Okay, so it's essentially curving around the abdomen. Now, this purple structure here is the inferior vena cava, and you can see that the hepatic veins are draining into the inferior vena cava. And like I just mentioned, the left hepatic vein does not exactly correspond to the plane of the falciform ligament. Okay. Now at a lower section, now you can see that that the heart is no longer visible, and you can see the cross section of the stomach. So we are at a lower segment, lower cut section. So at a lower cut section, again you can see the more of the segment 2. You can see segment 4A. Okay, you can see 8 again and segment 7. So these are essentially the same segments, but now in addition to that, you can see the caudate lobe or segment 1 that is slightly anterior to, just abutting the inferior vena cava. So this is the IVC. and this would be the caudate lobe or segment 1. Okay, fine. Now this is at the level of the bifurcation, or this is just above the level of the bifurcation of the portal vein. So you can see the left branch of the portal vein also here. And then at the next slightly lower level, you can see now you come to segment 3. Okay, so here you can actually see more of the kidney, the spleen, lower aspects of the spleen, the colonic flexure is also visible. Okay, and now you find that the segment number 3, which is below segment number 2, is visible. Then segment number 4b, which is below segment 4a, is visible. Again, segment 5, which is below 8, is visible, and segment 6, which is below 7, is visible. Okay, and again you can see the right hepatic vein, middle hepatic vein, major hepatic veins, right major hepatic vein, right middle hepatic vein, and again, as you can see, there is no left hepatic vein within the section that is passing in between, or that they're in the plane of the falciform ligament. Okay, so this is segment 1, like I just said, or the caudate lobe. This is also segment 1. Note the exact anatomy, that is, it's directly anterior to the inferior vena cava, and in actuality, in gross anatomy, this area of the liver corresponds to the bare area of the liver. Now, when you do CT imaging of the liver, there is a standardized protocol for when to image if you're giving contrast. So there are 3 phases. There is the arterial phase. There is the vein, that is 15 to 30 seconds post bolus trigger, and this is usually corresponds to around 35 seconds to 45 seconds after injection. So this is post bolus trigger. Trigger is basically a threshold at which the CT machine, threshold of attenuation at which the CT machine decides that the image needs to be acquired and processed. Okay, so the second phase is the portal venous phase. Now, the portal venous phase is importantly different from the arterial phase, because here you can actually see the branches of the portal vein quite clearly. Okay, in the arterial phase, you can see that there is, in this particular patient's liver, there is some kind of excessively enhancing structure here, and in fact here as well. So what this is actually a hepatocellular carcinoma. A normal liver would have this kind of uniform attenuation, and there are very few pathologies that show this kind of arterial hyperenhancement, hypervascular mets, and this essentially. So we'll talk about that at a later date. Anyway, in the portal venous phase, you can see that that same lesion is no longer clearly visible. Now, the portal venous vein is defined as a section that has been taken 60 to 75 seconds post injection, and this is independent of the arterial timing. Okay. Finally, we have the delayed phase. The delayed phase can be taken anytime between 120 seconds to 5 minutes, that is 600 seconds post injection. Now, as I just said, the arterial phase is most useful in picking up hypervascular lesions of the liver. Okay, so when we talk about liver mass in space occupying lesions within the liver parenchyma, later in the series, we'll be talking about this. The arterial and early portal venous phases are both essential for assessing the alterations in hepatic perfusion, which is actually what we're about to discuss just now. Now, let's first talk about the obstruction to the biliary drainage and diffuse hepatic inflammation. So, as I've discussed previously, it is when you suspect extrahepatic biliary tract obstruction that you will go ahead with imaging, and this is in most situations. Barring when you're suspecting elevation in ALP levels due to, uh, you know, primary biliary cholangitis in a patient with localized cutaneous systemic sclerosis or primary Sjogren's syndrome or something like that. So in that situation, you're quite clear, and even then we do rule out extrahepatic biliary tract obstruction. But how far we go with that process of ruling it out depends on what the pretest probability is. So say it's a suspected PBC case, we would probably just do an ultrasound. If that is the patient has no other pathology that explains it, then we may go for more advanced imaging such as contrast enhanced CT or a MRCP, as we just discussed. Okay, so for an intrahepatic biliary duct dilatation, we look for the findings in the ultrasound of the liver and in the CT abdomen. So in case of the ultrasound, this is what we see. So we compare the diameter of the biliary radicals and compare them to the corresponding portal veins. So the biliary radicals and the portal veins obviously go together, and you can confirm that it is the portal vein by putting a color Doppler probe there. And obviously there is significantly more flow in the portal vein than there is in the biliary radicals. Also, the flow would be going away from the probe. Um, Now, in this situation, you can see that the diameter here is more than 40% of that of the corresponding portal vein. Okay, so that means there is intrahepatic biliary duct dilatation. Now, similarly, on a CT abdomen, we prefer to do this in the portal venous phase because again, we'll be able to see the portal vein better. Okay, and again, the cutoff is the same. The biliary radicals that are corresponding to the portal vein should be more than 40% of the diameter of the corresponding portal vein. Now, importantly, please remember the biliary radicals are obviously going to be full of bile, which is mostly water, so they will have water density. Now, in this case, here the patient has also been given oral contrast. Okay, so portal vein. Okay, so rather not the portal vein, the biliary radical diameter is more than 40% of the corresponding portal vein diameter, and this has been confirmed by a color Doppler here. Now, in case of extrahepatic biliary duct obstruction, we do magnetic resonance cholangiopancreatography. This is a very fast, heavily T2-weighted sequence in which we use thick slices in a patient who has been fasting for more than 4 hours. So that's a lot of things to digest. Essentially, I'm not going to go into the details of this right now because this requires relatively deep understanding of how MR imaging is done. So essentially what we're doing is we are doing a very fast image acquisition because we want to nullify patient movement and artifacts that would result from that. We want to image the water within the extrahepatic biliary apparatus, and for that, since water has got a longer T2 relaxation time, we heavily T2 weight the image. And finally, we take very thick slices because we want to make 3D reconstructions of these images, and that's how we go about the thing. Okay, and the patient is kept for fasting for 4 hours because we want the secretions within other luminal tracts within the abdomen to be minimal. Okay, so this is just for completion sake, but typically we use 3D oblique coronal planes, and this is usually we rely on something known as a spin echo based sequence. Okay, a spin echo based sequence is essentially a technique where 180 degrees usually or other refocusing pulses are used to get the dephasing protons of hydrogen back into phase transiently, and then imaging is done as they come back into phase regularly. So there are different names given to such techniques, just again because of the fact that our exams are memory based often. I just wanted to come for completion sake, I wanted to mention them. So the first one that is used is HASTE. HASTE stands for half Fourier transform acquisition single shot turbo spin echo. Okay, so turbo spin echo is just another name for spin echo imaging, and half Fourier transform actually refers to the way in which the K space is filled in these cases. So again, I'm not going to go into the details of that. Now, FRFSC is fast recovery with fast spin echo, and the last one is rare, that is rapid acquisition with the relaxation enhancement. So these are the three sequences that are done, and it's best you need to know the names. Uh, as of now, that is enough. There's a lot of nuance to this, and we'll talk about this later. Anyway, the image that comes looks like this. So as you can see in this image, we've got this is a maximum intensity projection in order to maximize the bright structures in the image of an MRCP, and this is demonstrating normal anatomy. Now, importantly, here the S stands for stomach, so the patient was not kept fasting for long enough, and therefore there is some fluid within the stomach and the duodenum. There is fluid within the gallbladder, so the patient was kept fasting, but not long enough. Possibly in individual patients, obviously there is significant variation. Now, only the main right and left hepatic ducts are normally visible on the MRCP image. So you can see this is the main right hepatic duct, and this is the left hepatic duct. Okay, they join in together to form or the common hepatic duct, or the main hepatic duct rather, and sorry, the common hepatic duct, and then the common hepatic duct goes downwards and is joined by a cystic duct. So that is this duct that is arising from the gallbladder and moving towards the common hepatic duct, and behind the duodenum the two ducts are joining possibly here. Okay, and after that the short arrow here points towards the common bile duct. The common bile duct along with the main pancreatic duct both open at the major ampulla of Vater, that is the major papilla that is with the ampulla of Vater within the second part of the duodenum, that would be here. Okay, if you look carefully, there is also another accessory duct here, which is usually present around 40% of cases, and that is known as the accessory duct of Versa, and that one, the main duct, is known as the duct of Santorini. It's something that you need to remember. Okay. Now, see, basically, where we say that there is intrahepatic biliary dilatation or extrahepatic biliary dilatation, if intrahepatic, if there is any intrahepatic biliary radical that is visible on the MRCP, because that is not normal. Okay, except for the main right and left hepatic ducts. Okay, otherwise, we use cutoff of 373. So 373 Kelvin is 100 degrees centigrade. So that's how I remember it. Okay, so 3 here is the cutoff for the common hepatic duct. So a common hepatic duct that is more than or equal to 3 millimeters is a dilated common hepatic duct. Okay. 7 is the common bile duct. So that is after the common hepatic duct and the cystic duct joined with each other. At this point, if the diameter is more than or equal to 7 millimeters, that is a dilated CPD. And finally, we have 3 millimeters for the pancreatic duct. Okay, so it's 3 millimeters each for the common hepatic duct, and the pancreatic duct, it's 7 millimeters for the common bile duct. Okay, now importantly, there is an important caveat here. Again, once we discuss the MR imaging in detail, this will make a lot more sense. But gradient recalled echo imaging is a group of imaging techniques that we use for image acquisition in MRI. Now, this is not ideally suited for taking MRCP because it is very susceptible to motion artifact, and again, flow related artifacts are going to have create an issue. So there is a type of imaging called Fiesta, which is better done when there is the fluid around which is the structures that you're trying to visualize is moving very slowly, like the CSF. Okay, we don't usually use it here, so that's just something that it's a factoid for now, but it'll make sense later on. Okay, now having reviewed the imaging, we come to important clinical scenario, that is isolated intrahepatic biliary duct dilatation. That would mean that the intrahepatic biliary ducts are visible, but the extrahepatic biliary ducts, that is the common hepatic duct, is less than 3 millimeters, the common bile duct is less than 7 millimeters, and the pancreatic duct is also less than 3 millimeters. So in that situation, what might be the cause? Okay, so one obvious thing that might be there is that the obstruction is in between the intrahepatic and extrahepatic portions of the biliary apparatus. So in that situation, it could be one of two things. It could be a portal biliopathy, that is when you have a portal vein thrombosis and the portal vein then undergoes revascularization and cavernoma formation or a cavernous transformation. As a result, it compresses the common bile duct that is right next to it. Okay, or the common hepatic duct and or common bile duct. The second thing that might happen is the hepatic artery may get occluded. So there might be hepatic artery ischemia. As we've discussed, this causes a cholestatic pattern because the only blood supply of the extrahepatic biliary apparatus is actually and in the intrahepatic biliary apparatus is just the hepatic artery. So if it is occluded, that entire structure will undergo necrosis. Now, it also happens with a tumor that is located at the porta hepatis, that is the hilum of the liver, and that such a tumor is usually a cholangiocarcinoma, and such a tumor is known called a Klatskin tumor. It could also be an intermediate between a cholangiocarcinoma and hepatoma. That's a discussion for a separate day. Now, there are other causes as well. So you have a congenital abnormality of the biliary apparatus known as Caroli's disease. which again I'll be discussing more in detail later on when we talk about cholangiocarcinomas, because it's a risk factor for the same. And then in case of acquired cases, if there is recurrent ascending cholangitis, you might end up getting primary dilatation. So this is very analogous to bronchiectasis in the lung. Now, finally, if there are stones or parasites, again, mostly at the hilum or at the porta hepatis, that will cause intrahepatic biliary duct dilation. So, this is a very peculiar clinical situation that arises in a patient with, again, right upper quadrant pain. You do imaging, you find that there is intrahepatic biliary duct dilation, but the extrahepatic, the biliary apparatus is not dilated. So, that these are the differentials. So, this is obviously a subdivision of the discussion that we've already had on the causes of biliary, common bile duct and portal tract obstruction. And these were the causes. So again, uh, just to reiterate, cholangiocarcinomas, stones and parasites can cause obstruction at the hilum or the porta hepatis, and therefore that can happen. And again, ischemia of the hepatic artery again can result in a stricture starting at the porta hepatis, so that can happen. And again, the hepatic artery obstruction that I've just discussed. Okay, so this is what we have already discussed, and this is how this presentation ties into what we've learned already. Now, talking about imaging in the diagnosis of hepatic venous congestion. So, in case of hepatic venous congestion, something very interesting is that decreased hepatic venous drain always results in a very peculiar finding known as mottling. Okay, and this is actually regardless of cause. All this indicates is that there is a variable perfusion of the liver, blood perfusion to the liver, and therefore this can happen in any cause of impaired outflow, venous outflow from the liver. Okay, so it could happen with with the hepatic vein obstruction. It could happen with right atrial pressure elevation. It could also happen with sinusoidal obstruction syndrome. Okay, so you can see that there is mottling, and mottling essentially means that there are, interspersed, almost enmeshed, intermingled areas of differential attenuation. So as you can see, this much area is actually enhancing quite well. Then surrounding area is not enhancing as well, and again this area is not enhancing well. So that's mottling. Okay. Now, there's another interesting thing. This is actually a hepatic artery. You can see a little bit of contrast getting, pushed back into the hepatic, not the hepatic artery, the hepatic vein, and you can see a little bit of contrast, leaking back into the hepatic vein, indicating that that hepatic vein, that this would be the left hepatic vein, is actually open. Okay. Uh, Now, another important thing that to notice is this is fluid attenuation here. So this fluid attenuation within the peritoneal cavity naturally is ascites. So the patient has prominent ascites, again indicating that the patient has a hepatic venous outflow obstruction. Okay. So this would be due to either a hepatic, an increase in right atrial pressure causing passive hepatic congestion, and the presence of this, contrast leakage into this thing is a little bit indicative of that. Then hepatic outflow obstruction syndrome, that is Budd-Chiari syndrome, and your sinusoidal obstruction syndrome. Okay. So how do I differentiate between these three entities? So passive hepatic congestion, Budd-Chiari syndrome, and sinusoidal obstruction syndrome. So the site of obstruction in passive hepatic congestion is there's no obstruction, there's just increased right atrial pressure, and that is causing the pressure within the inferior vena cava, and therefore the hepatic vein to rise. In case of Budd-Chiari syndrome, we have the inferior vena cava and or one or two or more of the major hepatic veins directly getting obstructed. Okay. But again, it could just be inferior vena cava, it could just be the hepatic veins, it could be a combination of the two. So the exact permutation doesn't really matter. Then we have hepatic venular level obstruction, which is hepatic sinusoidal obstruction syndrome. So we've discussed the causes in the previous video in part 2.4. Please have a look at that if this does make sense to you. So again, nutmeg liver or mottling would be present actually in all three conditions. Okay. IVC or hepatic vein Doppler findings are the main thing that differentiate. Although, like I just shared, a leakage of contrast from the right atrium back into the hepatic vein or the inferior vena cava also does point towards this. So now, in case of passive hepatic congestion, we find typical findings of increased right atrial pressure, which has already been discussed in our approach to chronic dyspnea. That is. This thing interpretation of 2D echo findings in patients with chronic dyspnea. So that was part 5 in that series. Okay. And in case of Budd-Chiari syndrome, you'll have a decreased or absent flow in obstructed veins, again, because there is a thrombus in the vein. There's an actual thrombus in the vein. In case of sinusoidal obstruction syndrome, the obstruction is actually proximal to the point at which we are doing the Doppler study, so everything will be normal. Okay. Now, in that discussion, we had talked about this. That is the Doppler waveform that you get when we put the probe in the hepatic vein or the inferior vena cava. So what we found was that the normal waveform is like this. Okay, this is the normal waveform. So this is one cardiac cycle. So this is tricuspid valve opening and this is tricuspid valve closure. So tricuspid valve opens in diastole. So this entire thing would be diastole, and after that it closes in systole. So the rest of it is systole. Okay. So during diastole, essentially the inferior vena cava and therefore the hepatic vein, because it drains into the inferior vena cava and there are no valves in between, it functions as a conduit. So that is called the conduit function. Usually, because it is a conduit and there's no increased blood pressure within the right atrium, sorry, or the right ventricle, there's no problem in that, and therefore the flow is not very significantly reversed. Okay. Now, reversal actually only occurs with atrial contraction. Okay. So the atria contracts, blood flows from the atrium in the right ventricle, but also into the IVC and into the hepatic vein. So that is your reversal, the atrial reversal. Now, similarly, once the tricuspid valve closes, then the hepatic vein, the inferior vena cava, and the right atrium are one continuous chamber separated from the right ventricle. So in that situation, they function as a reservoir of blood. So if there is more blood to be there, then the flow rates towards the right atrium would decrease. Okay, so essentially what ends up happening is if there is increase in right atrial pressure during the reservoir function, that is before the tricuspid valve opening, the flow rates are less fast while moving towards the right atrium. So the curve moves up like this. Okay, and during the conduit function, actually there will be faster flow because as the valve opens, the pressure between the right atrium and the right ventricle is more. So as a result, the graph falls down a little bit more. Okay, and then there is atrial reversal, which essentially remains the same. So this is what we discussed there, and therefore a Doppler of the hepatic vein essentially is able to tell you whether or not the pressures of the right atrium are elevated or not. Okay, so this is what the normal waveform looks like. Okay, so again, you can see this is the atrial reversal. Sorry. So, uh, so as you can see here, this is the atrial reversal. Okay, this is when the waveform is behaving like a conduit. The IVC and the hepatic vein are behaving like a conduit, and this is when they are functioning like a reservoir. Okay, so this is the reservoir function, this is the conduit function, and this is the atrial contraction. Okay, now okay, so that is that. Now here what has happened is the reservoir function has become reversed. So the pressure is so high that actually there is reversal of flow at that point of time. Okay, so that is what's happening there. And then we have our conduit function. Conduit function, the pressure has increased, the reversal of flow, rather the forward flow has increased very significantly because the right atrial pressure is very high. So the flow from the right atrium to the right ventricle on opening of the tricuspid valve, which would occur here, is very high. And finally, the atrial contraction is also high because this indicates that the right ventricular pressure is high. Okay, so obviously right atrial pressure is rising because right ventricular diastolic dysfunction is there. So that is raised RA pressure. And for the details of this, I would refer you back to that discussion. That is part 5 on interpretation of 2D echoes for the internist. Okay, now you can also see a very prominent respiratory phasicity in the changes, and again I've discussed it in detail there. So now in addition to this, even on imaging without doing an Doppler ultrasound, acute hepatic venous outflow obstruction can have some other additional findings, okay, all related to the abnormal flow patterns that we see. So the first finding is what was called the flip-flop sign. So the reason for this is the loss of pressure, that is the pressure loss, which is technically called the major head loss, which as we've discussed on our discussion on the histological variants of FSGS is directly proportional to the length of your length of pipe as per the Darcy-Weisbach equation, through which the perfusion is occurring. So the longer the portal vein is, so if a branch is arising from this part of the portal vein, which is close to the bifurcation of the portal vein, versus this part of the portal vein, the pressure here will be lower and the pressure here will be slightly higher. Okay, because here the blood is only had to pass through this much of the pipe, that is the portal vein, and the other situation it has had to pass up till here. Okay, so because of this, what ends up happening is then the pressure in the branches of the portal vein in the center of the liver is relatively high as compared to the pressures that are perfusing the periphery of the liver. Okay, and please remember the portal venous pressure or the pressure within the portal vein minus the pressure within the hepatic vein is actually the perfusing pressure here. Okay, so if this pressure is lower, the amount of blood going there will decrease. Okay, so the flow rates will decrease. So since rate is flow per unit time, the perfusion to the center of the liver will occur earlier than the contrast will reach the center of the liver earlier as compared to the periphery of the liver. Now, uh, so that is what happens there. Another thing that can happen is the periphery of the liver, the flow can be so low, okay, because the hepatic venous pressures are so close to the portal venous pressure that essentially they do not undergo hyper enhancement after giving contrast. So this is the same mechanism. The pressure in the hepatic venous system is so high that the pressure in the peripheral branches of the portal vein never exceeds that in the hepatic veins, and thus there is actually a reversal of flow in the periphery of the liver. Okay, so that is what ends up happening there. Now, there are three other patterns that you might be able to see. Okay, sorry. So this is the same thing. Yeah. So now what we see is in this particular image, what you see is this is the portal venous phase or the early portal venous phase. What you find is that the center of the liver, that is the caudate lobe and the surrounding liver and parenchyma, is hyperenhancing, whereas the rest of the liver is actually hypoenhancing. Okay. Now, again, as we go forward, what we find is the center of the liver then becomes hypoenhancing because the contrast is already washed out. It is now that the rest of the liver is starting to become relatively hyperenhancing. Okay, so this is a flip-flop. Okay, initially the center was hyperenhancing, then the periphery became hyperenhancing. So this is known as the flip-flop sign. Then we have what is known as the peripheral liver hyperattenuation. So as you can see, there is a irregular area of the liver here that is showing decreased attenuation. Obviously, this is the portal venous phase because the portal vein is taking up contrast. So decreased attenuation in the periphery of the liver because again the probably the right hepatic vein is obstructed in this particular case. Okay. Now, yeah, so this is the reference. And now, when the process becomes relatively chronic, what ends up happening is there are some changes that occur in particular phases. Okay, so once it becomes chronic in the arterial phase, what you end up getting is what is known as a comma-shaped collateral. Now, comma-shaped collateral looks like this, and as you can see, this is enhancing in the arterial phase. You can also see there are other collaterals located on the abdominal wall of the patient. There is also a collateral located in the retroperitoneum, which is actually the azygous vein. Okay, so there are collaterals within the liver, there are collaterals outside the liver, and this indicates chronic blood carrier syndrome, although does not always correlate with what's true chronic blood carrier syndrome, that is on biopsy you find fibrosis. Okay. Now, in the portal venous phase, you might find something that looks like focal nodular hyperplasia, and we'll be talking about focal nodular hyperplasia when we approach intra-hepatic space occupying lesions. And but important, suffice to say for now, focal nodular hyperplasia tends to show hypoenhancing stellate scars in the middle. So in the portal way, in the portal venous phase, so what you find here is this area is hypoenhancing. Okay, and that hypoenhancing area surrounded by a hyperenhancing area is, it looks like focal nodular hyperplasia. It technically is focal nodular hyperplasia. So that is relatively indicative of this thing. Okay, so this is the largest nodule here is showing that. There are other smaller nodules also which are showing hyperenhancement in the portal phase. Now, In the third thing, what we find is in the portal venous phase, we find very significant hypertrophy with hyperenhancement of the portal of the caudate lobe. So as we had discussed just previously, this is the IVC. Anterior to the IVC, the caudate lobe is only this big in most situations, as we had seen earlier. But in this particular patient, the caudate lobe is this large. Okay, and the left hepatic lobe is just this small beak-like extension. So as you can see, the left lobe has undergone has become attenuated, or it has become atrophied, and that indicates that there was left hepatic vein obstruction previously. Okay, so that brings us to the end of this discussion. Essentially, these are the things that we've discussed. We've talked about the role of imaging in the diagnosis of biliary tract obstruction, the role of imaging in the diagnosis of hepatic venous outflow obstruction. We've reviewed the liver anatomy, that is the Couinaud segments, general features in contrast enhanced imaging of the liver, and we differentiated Budd-Chiari syndrome from elevated right atrial pressures and sinusoidal obstruction syndrome. The other topics I'll be discussing in the next section on this particular series. So that is it for now. Before leaving, we'll just finish this off. So again, like I said, this case vignette indicates that there is significant localized abdominal pain without vomiting, but associated with significant ascites due to parenchymal organ distension. Okay, and we've narrowed it down to it's most likely due to hepatic venous outflow obstruction. So what imaging would I do? Would I do a CECT? Would I do a ultrasound, MRCP? What should I do? So the answer to this naturally is I would do an IVC and hepatic venous Doppler. Okay, that would give me an idea. That would allow me to differentiate between the three possible further causes. That is your hepatic venous outflow obstruction due to right atrial pressure elevation, in which case, as we've seen, there'll be a change in the waveform. Due to hepatic venous obstruction, in which case in that hepatic vein there may be no waveform at all, and it may be due to sinusoidal obstruction syndrome, in which case the waveform will be completely normal. So that brings us to the end of this discussion. I'll see you in the next one. Thank you for watching.